Don't miss this video if you want to learn the approach to hypokalemia in less than 150 seconds. Now, a patient comes to you with serum potassium less than 3.5. You rule out any cardiac dysfunctioning or emergency situations, treat accordingly. You rule out pseudo hypokalemia, needs no treatment. You rule out decreased potassium intake, treat and reevaluate. Or there is transcellular shifting due to insulin excess, beta 2 agonists, or hyperthyroidism. After ruling these four things out, you move on to check the potassium levels in a 24 hours urinary sample. If it is less than 15 millimole per day, that means the loss is extrarenal. So you check the acid base status. If it is acidosis, that means it is a gastrointestinal loss. If it is alkalosis, that means it is due to diuretic or profuse sweating. Now you check the urine potassium levels and it comes to be more than 15 millimoles per day. That means it is a renal loss. So you evaluate the transtubular potassium gradient. If it is less than 2, that means it is due to increased tubular flow or osmotic diuresis. If it is more than 4, that means there is increased distal tubular potassium secretion. Now you check the blood pressure and volume status. If the blood pressure is increased, you check for aldosterone. If aldosterone is increased, you check for renin. If renin is also increased, that means it is due to renal artery stenosis or renin secreting tumor or malignant hypertension. But if with increased aldosterone, the renin levels are normal or low, that means it is a case of primary hyperaldosteronism or familial hyperaldosteronism type 1. Now, if the blood pressure is increased but aldosterone is not increased, you check for Cushing's, that is cortisol levels. If they are increased, it is Cushing syndrome. Okay, but if the cortisol levels are not increased, aldosterone is not increased, but BP is increased with hypokalemia, that means it is due to licorice, that is moiety consumption, or it is a syndrome of apparent mineralocorticoid excess. Now, if you check the blood pressure, it is low or normal, then you move on to check the acid-base imbalance. If it is variable, that means it is due to addition of a non-absorbable anion, either penicillins or hippuric acid. If it is acidosis, that means it is either a metabolic acidosis like diabetic ketoacidosis, or it is a case of renal tubular acidosis, that is proximal or distal. But if it is alkalosis, then you will have to check urine chloride levels. If urine chloride is less than 20, it is due to gastrointestinal loss, vomiting or diarrhea. But if it is more than 20, then you will have to differentiate between Bartter and Gitelman. You check for calcium to creatinine ratio. If it is more than 0.2, then it is due to Bartter syndrome. If it is less than 0.15, it is due to Gitelman syndrome.